weight loss is the primary outcome that's studied in the study, but that's not a patient-centered outcome necessarily. That's not a health-centered outcome. That's just an outcome that's presumed to be positive
Mm-hmm.
without actually any basis. But then in the exam room, when I'm seeing my patients and I'm counseling them, I'm like, is that actually the outcome that this patient is going for, or that is right to be focusing on at this time? So it's just the way you have to reinterpret the data that's out there for what's right for that patient and focus on the behaviors that we know are associated with improved health rather than more disordered, unhealthy behaviors that might lower the weight number but make everything else worse.
Hello, everyone. Welcome back to the channel, or welcome to the channel if you're new here. I am delighted to have with us today Dr. Rebecca Berens. She's a weight-inclusive primary care physician and the founder of Vita Family Medicine, which is a direct primary care model in the Houston region, which I'm delighted is close enough for me to meet you in person. And I cannot wait to dive into our discussion about how you help people from a health at every size perspective. But before we do, Rebecca, thanks so much for joining me.
Yeah, thank you so much for having me.
And for the people who have not yet met you, would you mind sharing a little bit more about yourself and what makes this such an important topic for you?
Yeah, so I'm a family physician in Houston, and I went into medical school very focused on wanting to help people live their lives healthier, and in the best health that they can. Very focused on preventive care and all those things. But I did have my own struggle with an eating disorder in college, and so I was very aware, even going into medical school, the impact that physicians can have in the way that they speak to patients about weight and health in affecting body image and affecting, disordered behaviors. And so that was something that I always was taking into account when seeing patients myself, but also observing in the way that these things were talked about in the medical education space, like observing where that was coming from. And so that's something that I really wanted to make sure that I addressed in my practice in a way that I felt was right for patients.
And I'd love to expand on that because you and I share that, especially going through medical school and having a lens from a lived experience of an eating disorder, the impact of the way we're taught and the way that physicians typically communicate with patients. Can you expand a little bit more about what you were observing?
Yeah, so I mean, I will say to the credit of my medical school, we did a lot of work on implicit biases in our training. We had a specific course, it was called Patient, Physician, and Society, where we talked about those like soft things, like bedside manner and, the socioeconomic and psychological factors affecting our patients, and addressing our own implicit biases about those things. And I remember very vividly one of the times that we had that class, we did the implicit association test that was developed at Harvard. And there's
Hmm.
implicit association tests for a lot of different biases, race, gender, all these things, but they also have one for weight. And I was like fairly fresh out of my recovery at that point. And I was really interesting because I had an implicit bias towards smaller people based on that test. And most people in the room had an implicit bias towards larger people. And so I think it was just very obvious, like everyone had a bias. And it was one that I felt like people felt was less valid or less important to be talking about compared to like obviously race. People are very aware of the racial history that has affected our country and people's experience with the medical system in particular. But it was almost like not um not deemed as valid, I would say, by some of my classmates. And like the way it was discussed just felt very upsetting. And you can just tell, the way that whenever we're talking about a study and like weight loss is the primary outcome that's studied in study, but that's not a patient-centered outcome necessarily. That's not a health-centered outcome. That's just an outcome that's presumed to be positive
Hmm.
without actually any basis.
Hmm.
And so that was just something that came up a lot that I just noticed over and over and over again. But then in the exam room, when I'm seeing my patients and I'm counseling them, I'm like, is that actually the outcome that this patient is going for, or that is right to be focusing on at this time? So it's just the way you have to reinterpret the data that's out there for what's right for that patient,
Hmm.
can be a little different.
And I appreciate you thinking and saying that because oftentimes what sells right now is weight loss. Everyone that's like, we're really well aware that health measurements of health aren't directly correlated to weight, yet because it sells, people will continue to leverage that. And whether they mean to or not, it is a reality. And also the amount of money that diet culture is making in leveraging people's vulnerabilities, because people are always taught to want, like, desire weight loss. It's interesting. I'll share a personal story really quickly before I ask my question that was coming from that. Is so I recently regained a significant amount of weight from a very malnourished place because of anorexia. Well, then I went to a primary care doctor's visit and told her about the weight difference, though she didn't know my current weight or anything else. She immediately counseled me on diet, weight loss, exercise. And she has my chart. I was medically discharged from the military for anorexia. So she was refusing to listen to any of my other reasons for. I was on the phone calling her and asking her for a workup. I was really concerned I was going into heart failure, which is a risk of anorexia, a risk that I was very acutely nervous about in historical treatments. And in my chart, she even says counseled veteran on diet and weight loss. So I was blown away. I've eventually switched primary care doctors because she wouldn't listen to me even as I was advocating for myself. But that's me as somebody who's very acutely aware of the medical hazards of directly focus on weight. So if we were thinking about the healthy at every size model and supporting people in kind of opening up their mindset about some of the challenges and some of the identified things we need to really be mindful of when it comes to utilizing weight as a measurement of health, what comes up for you, and what can you share with me from your expertise?
Yeah. So, I mean, I think when I'm talking to my patients, like weight is certainly it is an objective measure that we have that can be trended over time that can give us some information about what might be going on with the patient. So it's not as if it's a completely useless number to have, but it's never the number that I focus on as an outcome. And I think it's so hard for patients who have been so focused on that for a long time to make the connection that like you can actually engage in healthier behaviors, you can lower your blood pressure, you can improve your blood sugar numbers, you can improve your cholesterol numbers, but your weight might stay the same or go up or go down a little bit, but not as much as you have been told it needs to. But all these other very objective, data evidence-based measures of health outcomes and metabolic health are improved, and the weight number is the same. And that's a really hard mental shift for people to make because that's not what we are told our entire lives. We're always told like if you're overweight or your weight is too much or your weight is too whatever, your shape is this way or that way, it's unhealthy no matter what. But it's like you can actually make a lot of behavioral changes that will impact these numbers and your weight may never change.
Mm-hmm.
And it's a constant conversation and it's a source of struggle for patients too. Like I even had a patient recently say like, I'm doing all these things that I know are healthy. I'm eating regular balanced meals. I'm moving regularly. I'm getting enough sleep. I'm not drinking alcohol. I'm not smoking, but I still constantly wonder if I'm healthy. Because they're constantly getting this messaging of like, you're not healthy, you're not. And I'm like, you're one of the healthiest people I see
Yeah.
doing all of these behaviors consistently and, working on your mental health and all of these things. And yet it's this constant societal push of like, you're not healthy, counteracting the very objective evidence in front of you that you are.
And even thinking about anorexia and the current awareness that like atypical anorexia and anorexia are very much synonymous in many ways. And for me, thinking about people who often go undiagnosed or even celebrated for having an eating disorder, but their body size and body weight may not show the amount of suffering that they are experiencing. Can you talk a little bit more on that?
Yeah, and that's definitely those patients I think are the ones that struggle the most because they're constantly invalidated. Every time they'll go to the doctor and they'll tell them like I have a history of an eating disorder. I don't want to talk about my weight. And they're like, you can't have an eating disorder. Like your weight's too high. Like, that sort of invalidation constantly makes it so much harder to recover and heal. I think that's why for me, like the weight is sort of the last thing that I'm looking at. Like certainly if there's a drastic increase or a drastic decrease without another explanation, that's something we need to investigate. But the what I always tell people is like, I don't know where your final weight is going to fall. I don't know what your healthy weight is. I do know that if you have high blood pressure, if you have high cholesterol, if you have high blood sugar, like these are things we can address. That might include behavior change, that might include medication. We can address all of that, but we are not going to focus on trying to force that number into a specific range just because that's what you've always wanted to do or been told your whole life. And yeah, particularly for those patients, that's a big, a lot of the patients that I see, they're recovered, but they are still fighting that conversation in their head.
Yeah. What you said is definitely my experiences. For the amount of suffering I faced is actually utilized. It's usually when I'm in a body size that looks healthier, because then people really don't understand how much I'm struggling, or they say, well, you don't look anorexic, which I'm like, in my head, I know is shenanigans and is BS, but like that part of your brain can be like, say a lot of things and impact the way that you think about yourself, and then the way that you behave, and can potentially ignite someone's eating disorder. And for the people who find you and are sharing their experience of, oh my gosh, I'm so grateful that I found a physician like you because I've experienced trauma in the medical system, or things that have impacted me in a way that makes me really want to seek out a physician with your perspective. What kind of conversations are you having that you're hearing from patients' experiences?
Yeah, I mean, some of the things I hear, just like the statements that have been made to them in the past by medical staff or by physicians, some of my patients will tell me stories of what they were told, even starting from childhood by physicians or other people in the medical field. And it's often starting even as young as like 6 or 8 years old. They started, if they're in a larger body as an adult, they likely were in a larger body as a child, and they're just genetically going to be in a larger body. And they get comments at a very young age from doctors or from other medical staff, making little jokes about their appearance, or about like, oh, you have puppy fat or baby fat, and then very focused discussions on like, you need to lose weight, or you need to stop doing this, or stop eating this, or start doing this exercise. And it starts from a very young age, affecting their sense of self and the way that their brain is developing. And then, especially going through puberty, when there are a lot of body changes that are happening, and you don't grow height and weight at the same rate. So you may gain some weight and you haven't grown height yet. And so then you start thinking to yourself like, oh my gosh, it's happening. I'm going to keep gaining weight. This is what they told me. And that's when those sort of disordered behaviors kind of start. And it's when that is from such a young age into your brain, it's so hard to unlearn that as an adult. It continues to be that voice in the back of their head, regardless of how much work they've done in adulthood.
Mm. And also thinking about, you talking about the hormonal shifts in puberty. And also I hear a lot of women who are really having a loud inner critic during menopause, or if they have other hormonal dysregulations, such as like PCOS or other aspects of that. Can you discuss more on those medical conditions that impact someone's weight?
Absolutely. So, I mean, PCOS is a huge one. I see a lot of patients with PCOS, and PCOS is truly a disorder where there is insulin resistance, and there is sometimes weight gain as a result of insulin resistance that is from that metabolic dysfunction. And it can be so tricky because you want to address the metabolic dysfunction, but you don't want to focus so much on like your weight is a problem. It's more that your body is maybe not processing your sugar levels well, and so you are gaining weight as a result of that. That's a symptom. That's not the problem. That's a symptom of the problem. And how can we address that to manage that symptom for you, along with the other symptoms that come with PCOS? And there's so much body image issue with PCOS. Not all people with PCOS are in larger bodies or gain a lot of weight, but there can be excessive hair growth. There can be acne. So there's so much body image stuff that goes along with that. And so it's a huge contributor to developing eating disorder. And then certainly in menopause, the normal process of body change in menopause is we do store more fat around the midsection in particular, because of the gradual loss of muscle mass and the hormonal shifts that happen in menopause. And that is always looked upon as a problem or this is that your body, you're getting sicker as you age, this is a problem you need to fix, rather than this is a normal process that happens with aging. And yes, it does increase the risk of metabolic disease, but also we know that when you are older, having more body fat is protective against frailty and against death from infectious disease, which for many people now, but certainly for our ancestors, was the biggest cause of death. So it's actually a protective mechanism that your body has in place. And then not just frailty from infection, but also for your bone mass. Having that extra estrogen stored in some fat is protective for your bones. And so you have to look at the big picture. But I think because societally we are so focused on weight, doctors also are very focused on weight. And, we have a lot of metabolic associated chronic disease nowadays because we live long enough and we have a lifestyle that is conducive to that in the modern world. But it's not always a problem. Some of these things that are happening are normal human things, and it's a balance of addressing our lifestyle in the best that we can without outsized focus on the weight gain.
I really appreciate you showcasing that. And also my niche has head and neck cancer, and it's the prognosis goes down during treatment if your weight drops. So oftentimes they're counseled on maintaining their adequate nutrition as much as possible, and thinking if you started with a low reserve, your body's not going to have a lot of capacity to lose weight and kind of fight off the cancer. And so it's very interesting. And when you're thinking about the different types of education you've helped to inform your lens and shape your lens, is there anything that physicians can do now or patients you feel are important for them to read so they can at least start to expand their mind and look at weight in a new way?
Yeah, so I mean, I think there's a lot of great information out there, particularly from dietitians in the eating disorder world. I'm like Christy Harrison is one that I love, who's really good at summarizing the evidence. She has several books and a podcast that I've read, and she was sort of my first introduction to health at every size when I was in recovery, and that it just really resonated with me, and I've kind of stuck with it since then. But I think the biggest thing as a physician is just listening to your patient in front of you, and going in and don't even look at the vitals section. Don't look at the weight. Just listen to what they're telling you. And when you're thinking about your differential for, like, for example, I have a patient who had ankle pain and went to the doctor and was told, oh, you just need to lose weight. But they got the ankle pain from a Zumba class where they were doing a Zumba class, which they had been doing regularly to engage in movement, and they injured their ankle in the Zumba class. And it's like, what would you have said to a smaller person who came in with the same pain? Would you have told them, oh, it's because you need to lose weight? No, you would have examined their ankle. You would have gotten a history about when this pain started, what they were doing. You would have understood that there was an injury, and you would have counseled them appropriately on managing the injury. So sometimes it's just as simple as listening to your own patient. You don't need to necessarily go and get extra education. But I think informing yourself about your biases, take that implicit association test. It's free on the internet, at least for now it is.
Yeah.
And you can take it and you can see what your biases are. And then you can read, books from people who are living that experience and understand their perspective. And you can ask your patients, how they would prefer you to have these conversations. Like, would they prefer you to do their weight blinded? Do you have to do their weight at every single visit? Do you have to do their weight publicly in the waiting room, which I hear about all the time? And I'm just like, why? Why are you doing a weight publicly in the waiting room, and the medical assistant's literally calling it out in front of
No, that's
a
like
waiting room full
gym
of
class.
people?
Oh my
Yeah.
God. Do you remember that? Did you have that in gym classes? I remember the day I got weighed in gym class, and I developed early. And so like, this is a fifth grade experience, and they tell you it, they yell it to you, and I still remember how I felt because we remember those experiences in the way that made us feel, because all of my friends were in smaller bodies. And then eventually I was in a smaller body from anorexia, and people would compliment me until I was inpatient. And, I invite you to share as much as you would like to about your own experience in that regard as well. It just boggles my mind.
Yeah, I mean, I have always been genetically in a smaller body, and so I know that my experience is not even a fraction as difficult as the patients that I see, and even your experience of like being in a larger body and going through that treatment. But it is one of those things of like, as a child, constantly being told like, oh, you're so skinny, you're and praised for that. And then when you do start to gain weight in puberty, which is normal, you're like, oh my gosh, I'm not skinny. And it's funny because as you were telling that story, I have this very similar recollection to in seventh grade. we did this body fat caliper thing where you like, you pinch the fat on the back of your arm and it measures it. And I remember being like, I think mine was like higher than my friends or something. And I was like, oh my gosh, I'm not the skinniest anymore. Like
Mm-hmm.
something's right. Something's wrong. Like I've gained too much weight because I'm always the skinniest one, because
Yeah.
that's what I was always told.
Mm-hmm.
And yeah, it is very, I think that was probably the beginning. That was like the seed that was planted, but, it, it does, just get so ingrained. And I can't even imagine how much more difficult it would be if you were on the opposite side of the spectrum where you were constantly being told like you're too fat, you need to lose weight. Like I know how difficult it was for me, and that was not even a fraction of what other people experience. But yeah, and even now as an adult, going to the doctor, I'm genetically smaller. And so even though I'm recovered, like I just am on the smaller side, and having doctors praise me for my size when I go in.
Yeah. Mm-hmm.
And I'm just like, this is so irrelevant to the reason that I'm here and completely unnecessary to say. And if you're saying this to me,
Yeah.
what are you saying? Or what is your face saying? Or what are you thinking when you're seeing someone who's larger? And how can that not affect the care you're providing them?
Mm-hmm. Yeah, I get comments a lot, and it's interesting because I went to an eating disorder therapist, and I get comments a lot. I'm a runner, so I've always been athletic, so I've always just had an athlete's body aside from when I was very malnourished. And um at the gym, I actually had to stop going because I'd constantly get people coming up to me, and even if I'm at a level of my life where I'm vocal, I'm like, thanks, that's not helpful, here's why. Right. And like as an education, but also as a point to reduce the own chatter in my own brain, so it's more for me than them, because I know people don't learn. But people will then continue, right? Like they'll continue to say comments about like you're running, and I'm like, except for one person, he was a coach for people with addictions. And so he compliment on my running. And then I said, thanks, I'm actually struggling to reduce it. And then immediately he took on to that and was like, oh, well, then let me help you stop. Like, because he got it.
Mhm.
And then I was, in the moment of panic, I was like, shoot, I can't believe I just told him that. Now he's gonna stop me. But it's this people, if they, that's where their implicit bias is. If you have a body type that they think is desirable, then they think it's okay to compliment you on it. And I'm very vocal online with the eating disorder and anorexia, and because my weight's fluctuated over the years, people will still comment, and I'm like, damn, like you're somebody that follows me on social media. I can't assume you read every post, but I would assume that you understand like that the comment is probably not going to be that helpful. And I think that's where acknowledging that there's going to be triggers and activating comments made everywhere, and creating safe spaces like you have, where people are, because I anticipate many people, I've heard it, and you might have heard it for the people that do eventually come in, or if people are avoiding going out, but specifically avoiding medical care because of how it feels to be shamed for their weight.
Absolutely. I hear that all the time. And a lot of the times when I do see patients, like they're not up to date on basic screenings, pap smears, mammograms, if it's, applicable, those sorts of things. And it is because like if you don't go in, you're not having the opportunity to have that discussion about those screenings that could be beneficial for you. And then there can be metabolic conditions that have not been diagnosed
Mm-hmm.
and, would have been easier to manage potentially at an earlier stage, but now require medication. And then there's this sort of like self-blame on
Mm-hmm.
the patient side of like, oh, I did this to myself. And I'm like, right, but this could have maybe been addressed earlier. And it's not like you weren't coming in because of what you've experienced. That's not something that you should blame yourself for. But then when they go in, they are blamed for it. They're like, oh, well, you haven't been taking care of yourself all these years. Like, I haven't been coming in because I didn't want to
Mm-hmm.
have this lecture. And so that is a lot of times things that I see is just like not being up to date on things, having diagnoses that could have been caught earlier with proper screening. And, there's a lot of discussion about this, I think, in the health at every size community. I don't think it's been adequately studied is like how much of the outsized risk that we see for cancers and metabolic conditions are related to a true relationship with the weight and this diagnosis, or actually a lack of medical care
Yeah.
and that diagnosis being made later.
Mm-hmm.
Um,
Mm-hmm.
and, I think that's something that it's just sort of assumed that there's like, oh, correlation, causation, right? But it's like, well, maybe there's the correlation and there's another cause there that you're not
Yeah.
thinking about. And that's, like you said, that's not the thing that sells. So that's not what we are always studying. But I think it's an important question to be asking yourself. And I think it's just why it's important to not focus on so much on that number and to focus on the big picture. And focus on the behaviors that we know are associated with improved health rather than more disordered, unhealthy behaviors that might lower the weight number but make everything else worse.
Absolutely. And the shame and the stress and all those things that compound and impact someone's overall wellness. And thinking about smoking, well, you can, smoking, people smoke to lose weight all the time. And oh my gosh. And thinking about, so I just had a leap. I didn't get an HPV screening because I didn't want to get weighed. I've avoided many medical appointments because the impact that being weighed, because I've been through so many eating disorder visits and because I've been invalidated through it. So I share that with the people just like you are sharing so that they can know that they are seen and they are heard. And there are people like you out there that exist and that can provide a compassionate space for people to really feel safe again in their own self, because I think what ultimately happens is we don't feel safe in our own bodies, and then that could actually exacerbate the way that we treat our body. And so for the patients who are like, oh my gosh, finally we have you that's here, what types of patients do you work with in terms of like location? Is it all Texas?
Yeah, so I'm licensed in Texas, so I can see patients all throughout the state of Texas. I do always prefer to see my patients in person at least once a year, just, get a good thorough checkup in. So a lot of times what I'll do is I do have some patients that live in other parts of Texas. They're not in the direct Houston area. And they'll maybe come in for an initial intake appointment. We'll do their physical exam and then follow-ups we can do virtually periodically throughout the year. And then, like once a year-ish, we'll have them come back and do an actual physical. So it's like hybrid virtual. But it just depends on the condition that we're managing. Obviously, there's some conditions where I really do need to see you in person every time, and it wouldn't be appropriate for me to see you. And I can always tell people that if that's the case. But I can do consults as well too. If people just want to see like an initial consult and then have a plan that they can help advocate for themselves with their own PCP in person, that's always an option too.
Interesting. That's awesome. And where can people learn more about your practice?
Yeah, so the practice is called Vita Family Medicine. We're located in Sugar Land, which is just in the southwest Houston area. It's just outside of Houston. And our website is www.vitafamilymed.com. And there's actually a link there where you can just book a meet and greet, we call it, with our staff, and we'll kind of go over how the practice works and then help you decide if it's the right fit.
Well, thank you. You've definitely opened up this discussion. And I'm curious, is there anything else that we haven't explored yet that you want to make sure our audience knows today?
I think there's so many things that you and I could talk about, and I'm
Yeah.
sure we can talk about again in the future. But yeah, I mean, I think my biggest message would be for patients is like, you deserve to be able to access the care you need. And sometimes you just need a little bit of like help and support learning how to advocate for yourself. And I totally encourage you to do everything that you need to do to get that support so that you can advocate for yourself. The therapists and dietitians in the eating disorder world are all amazing, and they're really, really great at helping coach through this. But obviously, if there's more medical complex things that you're struggling with, I'm happy to help with that. And there's other amazing physicians too that are happy to help. And I know there's actually a new organization that I'm a founding member of called the Association of Size and Weight Inclusive Medicine. I think I'm saying that right. It might be weight and size inclusive. I can't remember the order, but it's we're working on a directory that we're going to put together to help patients more easily access the physicians that will help them with this.
Awesome. Well, thank you so much. And you're right. We could talk a lot about a lot of different things. So if patients or other physicians that are tuning in or other healthcare professionals or anyone that's tuning in today have any questions, anything they want us to expand on or circle back on, please share those in the comments below. If you want us to know your experience, what you would advocate for change, we'd love to hear from you. And Rebecca, thank you so much for joining me today.
Yeah, thanks so much for having me.
Yeah, I'm going to share your links and the link to the implicit biases for anyone that wants to check that out or those out. There's a lot of different ones you can check out in the descriptions below. And thank you so much to the audience for being here. Until next time.